Performing regional anesthesia in Covid-19 patients. Covid-19 disease, which is caused by Covid-19 virus, emerged from Wuhan in China in early December 2019. The severe acute respiratory syndrome, which is caused by this type of coronavirus, has rapidly achieved effective and sustained human-to-human transmission via contact, droplet, and likely airborne routes, and is probably fatal. WHO declared the COVID-19 disease as a pandemic on March 11, 2020, and requested for activating emergency reaction systems all around the world. As the anesthesiologists are at the front line of the management of critically ill or surgical patients, and with the rapid growth and spreading of COVID-19 cases, we can expect to encounter more of these patients in operation rooms and in intensive care units. Which anesthetic plan is preferred in this patient? Regional anesthesia is the method of choice, if applicable, for patients with COVID-19 in order to reduce the risk of transmission. Why regional anesthesia is preferred? Number 1. Because it decreases the need for airway manipulation. Number 2. It decreases an aerosol generating procedure like as intubation, of which subsequent aerosolization can potentially infect the healthcare workers. Number 3. It decreases the length of stay in PACU. Number 4. It decreases the length of stay in intensive care units and ventilator dependency. Number 5. It decreases the opioid needs and its subsequent side effects. Number 6. The postoperative analgesia with regional anesthesia further facilitates postoperative management. And number 7. It decreases the adverse effect of performing general anesthesia, such as hypoxia and postoperative nausea and vomiting. How to perform regional anesthesia? Always do it as a safe practice. So use appropriate personal protective equipment before doing the procedure and take extra time to don and off. As regional anesthesia procedures are not considered as aerosol generating procedure, so using N95 or FFP3 masks or similar powered air purifying respirators such as PAPRs generally not considered necessarily. So using goggles plus surgical mask are the minimum required PPE. All patients should wear a surgical mask to restrict droplet spreading. The ultrasound matching screen and controls are protected with a single-use plastic cover to prevent contamination and to ease disinfection post-procedure. Prepare and pack the required drugs in a plastic bag. Sedation should be used with caution in COVID-19 patients because they have difficulty in breathing. Using minimal supplemental oxygen is needed in order to maintain the situation. For upper limbs surgery, using blocks that have minimum respiratory interference, such as axillary or infraclavicular brachial plexus block, is recommended. Risk-benefit should be considered for preneural adjuvants and continuous preneural catheters. Currently, No dose adjustment for regional anesthesia is recommended in these patients. Always use ultrasound guidance for peripheral nerve blocks in these patients. Regional anesthesia successful block should be thoroughly tested before proceeding with surgery to minimize the need for conversion to general anesthesia. In case of failed block, if the need to convert to general anesthesia arises, the anesthesiologist should follow PPE guidelines and use an induction technique that reduces aerosol generation to the minimum. For neuroaxial procedure, rule out thrombocytopenia and coagulation profile. Watch and be prepared for hypotension after performing neuroaxial anesthesia. Postpone the epidural blood patch, if possible, until recovery from acute COVID-19 infection has occurred. Discard safely the plastic sheets covering the ultrasound machine. The ultrasound machine should be wiped down with disinfectant wipes or sprays.